Hello everyone and welcome to basically hypersensitivity reactions, which is, if not mistaken, chapter 7. So this is actually a really nice chapter to go on with. It's gonna be a lot of, let's say, clinical. Of course, I'm gonna talk a lot about the immunology behind it, but more the clinical basis, what these hypersensitivity reactions are in the clinic. So for anyone who's into into medicine or pharmacy or this kind of stuff, I think this will be a very cool lecture for everyone. So, what are hypersensitivities? So, as we know, the immune cells are able to protect our body against pathogens, toxins, and abnormal cells. We know this. This is basically one of the biggest functions of an immune cell is to protect us against all these things that I just mentioned. However, sometimes this immune response, so when the immune system is trying to actually help us against these things, it can be a bit excessive or misdirected, resulting in damage to our own tissues. These are called hypersensitivity reactions. When our immune system, so imagine these are basically, here you have basically basophil SpongeBob and eosinophil basically Patrick, that are trying to protect their town, which is your body, and they do it so well, but a bit exaggerated and a bit misdirected that they destroyed it as well. This is what happens in hypersensitivities, is when our immune system is trying to actually protect you, but it does it in such an excessive manner that it actually becomes very lethal to us, because you're now causing a lot of death, and it's actually can be excessive and misdirected. So rather than actually you wanting to protect us, you're actually causing damage to to basically to something else. So the whole mechanism, it's usually basically hypersensitivity occurs when the immune system reacts in an exaggerated manner to an antigen after a previous sensitization event. So what this means is that you need to be sensitized, meaning that this is your adaptive immune system. It's either your antibodies or your T cells. So you need to first be exposed to that antigen, and then your own immune system is then able, your own adaptive immune system is then able to create a response towards it, and that response is then basically causing the exaggeration. So always it starts with a sensitization event. So the first time you're actually given, let's say you're exposed to a toxin, it's not the first time that you will develop the hypersensitivity. Usually it's the second time. The second time, when you actually have a memory and you're exposed again, that's when you basically, that immune response starts to become very harmful. And this antigen can be very harmless. It can be literally substances like pollen, food proteins, some things we actually are exposed to constantly and they do nothing to us, but our immune system actually goes haywire. Or it can be actually a self molecule mistakenly recognized as foreign. So molecular mimicry that I was speaking about. And there's different types. There's type 1, 2, 3, and 4 hypersensitivities. They are basically all under one umbrella, which basically means your immune system is being exaggerated and is causing damage to yourself. The mechanism is what defines the type. So you have type 1, which we call IgE mediated hypersensitivity or immediate hypersensitivity. This is basically allergies. This is purely coming into allergies. Anything that has to do with IgE antibodies are type 1. So if you hear, hey, this basically hypersensitivity is mediated by IgE, type 1, straight away. Type 2 is also antibody mediated, but it's more IgG and IgM, because those two antibodies are able to actually activate our macrophages and complement activation really well, to sometimes that it can go a bit too far and it can actually kill us. So these are type 2. Still antibody, but more IgG and IgM. Type 3, also it is antibody. It's also IgG or IgM, but it's different. So how is it different to type 2? Type 2 is basically antibodies binding to proteins on cells. Type 3 are they're binding to antigens that are free and soluble moving, meaning that they're just soluble, they're in the blood. That's the difference. So type 2 is that the antibodies binding to the antigens in a cell membrane. Type 3, they're binding to antigens that are soluble. And then you have type 4. Type 4 is the most different out of all of them. They are not antibody mediated. They are T cell mediated. We're gonna literally give you examples of how they're all done and give you a lot of different types of clinical examples and where you see these things. So as I said, between type 1, 2, and 3, it's antibody mediated. It's only type 4 that's T lymphocyte. So what we see from these basically types of hypersensitivities, despite that all of them they do damage, they have a different immune component. So type 1 and type 2 and 3 are antibodies, and we know that they're even different. Type 1 is IgE, the other two are, IgG, GM, but they bind to different antigens. One is in the cell, basically type 2 is on the cell membrane, the other one, type 3, is soluble. Type 4 is completely T cells. The timing of the reaction is completely different. And then you have the mechanisms that cause the tissue injury are also different in some sort of manner. So how they're causing the injury. And of course, the disease that results from this process is also different. So we'll definitely go into so many examples to show you. So type 1 hypersensitivity, as I said, these are mostly mediated through basophils and mast cells. These guys, what they do is they love to bind to IgE antibodies, and they do love to cause us a lot of allergies. So the basic concept. Type 1 hypersensitivity, as I said, is purely mediated by IgE antibodies. So this is in bold. Please, please, please do not forget this. So, as I said, usually what happens is always in these cases is that you're sensitized. So something happens, you get an allergen. This could be pollen. This could be food. This could be penicillin. You name it. It's an allergen that for some reason our B cells are taking it up, and it's basically introducing it to a CD4 T cell. And it's basically from this, what is happening is that this B cell now is trying to create an antibody response against that allergen. And that antibody response is IgE. And this IgE is going to cause all the allergies that I'm talking about. So these allergens could be, as I said, pollen, could be dust mites, animal dander. These are basically components that you see in animals, be it from a cat or a dog, you name it. This could be foods, for example, like peanuts. This could be insect venoms or drugs like penicillin, for example. For some reason, we are actually very sensitive towards certain antibiotics, and one of them is being penicillin, the penicillin family class. So as I said, there always has to be a sensitization, which in this case, what happens, let's imagine that you are allergic to penicillin, or you're going to develop it. Let's put it this way. So you are basically exposed to penicillin for the first time in your life, okay? Because it's the first time in your life, you don't have an immune response against it. You've never seen this before, okay? What happens is that there's going to be a component from penicillin that's going to be taken up by your dendritic cell. This dendritic cell is going to then go to your lymph nodes and present it to your naive CD4 T cells. And it's going to do it through MHC2 class molecules. If there's basically a good, nice pairing of your MHC2 with your antigen towards your T cell receptor and everything, great. You're going to start to create this into T helper 2 cell. This T helper 2 cell will then go and basically, bind to another B cell that has the antigen as well. And it's going to basically teach it. This T helper 2 is going to teach this B cell, like, okay, create an antibody response against this antigen. So it's going to release. And yes, I need you guys to know this. Interleukin 4 and 13. Interleukin 4 and 13 are cytokines that T helper 2 cells release to B cells. And what that does, it causes the B cell to do a class switching. So rather than producing IgM antibodies, it's going to create IgE. So this is where the T helper 2 cells are directing the B cell what to do. Like, hey, you need to start going and doing class switching towards an IgE. Great. The B cell starts to create IgE antibodies that are specific towards this allergen, this penicillin allergen. IgE antibodies usually they're not free roaming in your blood. IgG antibodies are, IgA are, but IgE, not really. IgE, what it does, it binds to a receptor called Fc epsilon receptor. So remember, epsilon is basically, the Greek denotation of E. So that's why they denote it. So this is its receptor. So the IgE will bind to basically this Fc epsilon receptor. And this receptor is found on mast cells, on basophils, eosinophils. This is why type 1 are mediated by those kind of cells. and they bind, and they because it's such a high affinity kind of binding, they stay there. So what you have actually are mast cells with stuck antibodies, and these antibodies are the ones going to be recognizing whatever antigen. So IgE is usually not free roaming; it's usually stuck to a mast cell or a basophil, or basically an eosinophil as well. Then comes the second exposure, so your subsequent exposure. This was your first one, nothing happens. You do not get any basically symptoms. Once again, you go back to the hospital and you take penicillin for the second time in your life, this is where the allergy starts to happen. Because what happens is that now this antigen that you've created previously an antibody against is going to bind to it. And these antibodies are bound already to the Fc epsilon receptors, for example, in this case, into a mast cell. And this is going to cause this mast cell to activate. It's going to activate this lin and sic, basically kind of tyrosine kinases. I don't need you to know that, which causes a calcium influx inside. Again, don't need you to know that. And what causes this is this basically mast cells start to degranulate. They start to release a lot of molecules that gives us the symptoms. These are the itching, the nausea, erythritia, and angioedema, bronchospasms, cardiovascular collapse, anaphylaxis, you name it. This is type 1. This is how it's mediated, per se. When it comes to actually the mediators, these can be different types. These could be basically, histamines, tryptases, leukotrienes, all the different kinds. But usually, they come in phases. Usually you have we call them the immediate performed mediators. So these are ones that are directly. So what happens? So when you see actually a mast cell, you're going to see that it's very granular. Really, if you look at it in a kind of microscope, you see that you have a lot of these small little sacs. Well, these are actually vacuoles. Not vacuoles. These are basically, these kind of little bodies. These kind of, what's the right word for these ones? Endosomes. Little endosomes in there, basically, that are just all there. There's actually small little bodies over here that what they have is they contain histamine, tryptase, proteases, and heparin. And what happens is that once this basically is activated, these are immediately released. So you can see that these small little basically bubbles, which are basically your endosomes, are being released, and they're releasing histamines, tryptases, proteases, and heparin. And these are your first symptoms. This is why once you're actually exposed to an allergen, it's almost immediate that you get symptoms, because these are already done. You don't need to wait for the cell to produce them. No, they're done and they release them. After these are activated, so once these are released, your mast cells, basophils, and eosinophils start to create other basically mediators like leukotrienes, prostaglandins, platelet activating factors, and cytokines. These also basically will cause more the late effect kind of symptoms, specifically bronchoconstriction or mucus secretion and itching. So vasodilation, vascular leakage, they're mostly happening really early on, even also itching at the beginning, but it's mostly the late ones are the bronchoconstriction and mucus secretion, which are much more the cause of these guys that are doing them. And I'm going to give you here now examples about type 1 hypersensitivities. The first one, which is the most common one, and I'm quite sure a lot of you guys either have had it or have had actually a friend or relative have, your allergic rhinitis. Allergic rhinitis basically means it's more coming from your nose. So all these different types of diseases that I'm going to talk have almost literally the same type of mechanism. The only thing that changes here is simply the location. So allergic rhinitis happens in your nasal cavities. So what happens is your nasal cavity is exposed to an allergen, for example, pollen. The first time that you get exposed to pollen, nothing happens, but you get sensitized. You create IgE antibodies that are binding to your mast cells or basophils. They're binding to them, and they're literally waiting to be basically for your second exposure. Once the second exposure happens, they start to release the immediate, basically mediators like histamine, tryptase, protease, and heparin. And these are the ones that are causing basically all the itching and the sneezing. In the late phase, if you keep getting exposed constantly towards it, and your basophils and mast cells are being much more activated, Well, this is going to cause the production of leukotrienes, of these platelet reactors, all these different types. And they basically also start to bring up other kind of immune cells like eosinophils and T helper 2 cells. And these eosinophils and T helper 2 cells, specifically eosinophils, will release toxic proteins like major basic protein. And this actually will cause a huge chronic inflammation. So it actually can cause a bit of damage towards your nose. Your immediate ones are just causing literally your itchiness, the sneezing, these kind of annoying kind of, let's say, symptoms. It's only later on, these leukotrienes, prostaglandins, and these other when they start to bring eosinophils and they start to release major basic proteins. These are the ones that are causing the chronic, constant inflammation that is actually, causing a lot of damage to our nasal cavity. And this is in generally, allergic rhinitis is very, let's say, mild. Like, I've never heard of a case that it becomes very lethal because most of its location is still into the exterior. You're not damaging so much, let's say, vital organs. Another one that is, let's say, vital and it actually can be very deadly is your allergic asthma. So basically, again, you have the exact same mechanism, but the location differs. So here is that your allergen now is in your bronchi. The bronchi are these capillaries inside basically your lungs. These are the ones that have your alveoli that are doing the gas exchange. So these are bronchus, basically kind of capillary beds that are literally doing the gas exchange with the blood and everything. So what happens is they're getting exposed. So you have immune cells all around there as well. They're getting exposed to an allergen, and your whole sensitization is occurring there, and then your second exposure is occurring there, so you get to actually have inflammation inside your lungs. And this can really be very dangerous because you get asthma. You basically have the constriction of these capillary beds and of your alveoli that are not able to anymore do gas exchange. So you're not able to breathe, to release CO2 and bring in oxygen. So this is usually what happens at the beginning. So this is the early on, is that imagine this is your healthy bronchus, basically where you have this kind of capillary beds, basically in here. And basically here you have your alveoli. These are basically small little bubbles that are doing the gas exchange, the carbon dioxide and oxygen. So literally taking up oxygen and releasing carbon dioxide outside for us to breathe it outside. So what happens, this is how it should look like, is that when you're exposed to an allergen, you're sensitized. The second time when you're exposed to it, what happens is that your immune cells, specifically your mast cells and basophils, start to release the histamines, basically all these different type of things from the beginning that cause this whole literally kind of bronchi to start actually becoming much more inflamed. And because it's so much more inflamed, the airway starts to become very low, and the amount of oxygen that we're able to, let's say, kind of release or take in is extremely, extremely low. So this is why in asthma people have an issue with breathing. And of course, you start to have a lot of edema because there's an inflammation, a lot of water is being released, and a lot of mucus, all these different things. And of course, what happens in the late phase, basically once you go into the late phase, you start to bring basically eosinophils. Eosinophils start to come in, and they start to release a lot of cytotoxic proteins, like similar to what happens with allergic rhinitis. And this basically cytotoxic proteins will cause a whole remodeling. So it's gonna make actually the whole. So this is basically your bronchi. So all of this airway smooth muscle is gonna increase in mass. So it's actually gonna press on it and actually gonna constrict this kind of lumen. The lumen is the opening. So you actually, rather than here having actually quite a lot of oxygen, let's say 100% oxygen being released, this now becomes down to literally 30% of oxygen being released. So this is one of the things that happens. You also have increased basically thickening of the airway muscles and fibrotic tissue. Fibrotic tissue is literally tissue that has been damaged and been remodeled, and that tissue is not very elastic. It actually is very rigid, and something that you do not want. In your lungs, they need to be very elastic because they are the ones that are being basically expanded and contracted constantly, so they need to be able to do that. So this is all happening because of the late kind of chemicals that are coming on. These are the leukotrienes, the prostaglandins, which are bringing the eosinophils. Eosinophils are doing all the damage there. This is what happened. Again, similar to rhinitis, but the difference here is simply the location. Here comes with food allergy. So again, very, very similar stuff happening towards you. You're being basically exposed to an allergen in your intestine or in your intestine. So more in your gastrointestinal mucosa. And there is where they start your mast cells to interact with peanuts, shellfish, eggs, milk, soy, wheat, so many different types of things that can actually happen. And you start having a release of histamine at the beginning, and this causes, of course, the smooth muscle to contract a bit, and especially the intestinal walls. You get cramps. This is why you feel, let's say, very immediately very bad at the beginning, because histamine is able to do that. But then later on, you start to produce a lot of different prostaglandins, leukotrienes, which are actually going into your intestine. They're opening up your intestine. They're being much more permeabilized, so they're really going more systemic towards your blood and your skin. And what you get is this urticaria, which basically is this not a rash that you see, because the histamines are opening up your intestine. You're also getting a release of prostaglandins and leukotrienes, which are also opening up your intestine. They're your intestine becoming leaky. It's releasing all these things into your blood, so it's able to go into your skin. So this is why certain people, when they actually eat certain products like peanuts or shellfish or whatever, they get these kind of rashes occurring. The most severe is anaphylaxis, and this is more when it hits more systemic. So rather than being located to one, let's say, specific area, it's everywhere. And this is basically it's the most severe form, and your allergen is just going everywhere. And your mast cells and basophils are being activated basically everywhere around your body. So what happen is that they have this massive release of histamines and leukotrienes all around your body. So this can go into your vascular, into basically your veins and capillaries, which can actually cause vasodilation, increase permeability, and this can do a lot of leakage of liquids, which drops your blood pressure. This is dangerous because we know hypotension can kill you. It can go into your lungs and can cause the whole bronchoconstriction, so your bronchi being constricted, you're not able to breathe. It can go even to literally your larynx up here and stop the airway, so you're actually obstructing your breathing. So it goes everywhere, and basically this is also a form of anaphylaxis, and where basically your skin is getting so inflamed with edema to the point that you're not able to open up your eyes. So this is the most severe type 1 hypersensitivity you can get. And usually when you actually known to actually, let's say, have anaphylactic shocks, for example, this happens, for example, with peanut allergies. Peanut allergies can actually then go, rather than just in the intestine, it can also go into your whole system and induce a mast basophil and xenophil, basically, kind of activation all around. You need to have something called an EpiPen. An EpiPen is basically this kind of drug. It's literally a kind of an injection of basically epinephrine. And what the epinephrine does, it basically helps to vasoconstrict, it relaxes your bronchial smooth muscles, and it inhibits your mast cells from degranulating. So you're trying to stop all of these things that are occurring. Fun fact, basically these EpiPens, usually people that have, let's say, severe allergies, they usually have it. In Europe and other countries, basically it costs around, let's say, $80, $90. It's not so expensive. But in the US, this could be extremely expensive, like from $650 to $750. I've heard for some people that it can be even like $1,000 and plus. So these are extremely expensive in the US, which I have no idea why, because these are life-saving. Because if you have an anaphylactic shock and you don't have this in hand, you can die within literally minutes. So to me, it's ridiculous how the US is basically kind of putting them so high cost. Now goes to type 2 hypersensitivity. So type 2 hypersensitivity, as I said before, it's more IgG and IgM. Still antibody, but it's more these kind of antibodies. And specifically, these IgG and IgM are binding to cell surfaces or extracellular matrix molecules. So basically molecules that are either on a cell surface or on the extracellular matrix. They're present on something. They're not soluble. They're not just walking around. No. And what happens, and specifically, is that once they are bound, you can get activation of your complement system. You get basically also activation of your NK cells to start releasing granzymes of preference. You can actually get also macrophages to do basically phagocytosis, also neutrophils, and you can cause neutrophils to start releasing a lot of these really toxic molecules. And what you also can get, of course, is other than that, you can also block receptors. You can block the receptors and or basically cause receptors to be stimulated. And this can cause different types of diseases. So, give you examples. Hemolytic transfusion reaction. This occurs when basically you're given the wrong type of blood. So let's imagine that let's say I am a blood type A. I receive blood type B. So this is your red blood cells, which are type B. The type B, they have these glycolipids that are basically very different. That's what defines the types, is the glycolipids on the surface. So in this case, you have this glycolipid that is basically very different. What happens is that we get a sensitization. We basically, when we get exposed, we create an antibody against that type B. Okay, well, now the second time I get this transfusion, the antibodies in me will bind technically to type B, and it's going to cause the attack, your MACA complex conformation. This is your complement, which is going to basically bring other types. So basically you get release of C5a and C3a, brings macrophages and neutrophils. Macrophages here will start to basically phagocytose. You start basically breaking down all of these basically red blood cells. And what happens is that when you actually break these red blood cells, you release heme. Heme, the hemoglobin that is supposed to be inside these red blood cells, is very toxic. It can actually go into your kidneys and cause injury there. This is what we call acute kidney injury, which can be lethal. Another type, basically type 2, is hemolytic disease of the newborn. So I love to use these basically. So here it's more written what's happening, but I love just to explain using a diagram. So what happens? This is actually more also related towards red blood cells, but this is more, rather than just basically the group type, this is on the Royce antigen. For those who don't know what the Royce antigen is, this Rh antigen, the Rh antigen is basically you either have it or you don't. So this is why people are O positive or O negative, or they're A positive or A negative. This negative sign that we have is if we have this Rh antigen or not. So people are either born with or without it. Okay? So let's imagine that you're a mother that actually that is Rh negative. Okay? You basically are pregnant and your baby is Rh positive. So this is the red blood cells. They have this basically Rh antigen, which is shown here in these kind of blue little bubbles. What happens is that during your first pregnancy, once you're basically exposed to these red blood cells that have this Royce antigen, your mother is going to see that Royce antigen as basically something foreign. And it's like, okay, this is something that I don't know, and I need to create an antibody response. You create your antibody response, you create this anti-Rh IgMs, whatever, but you create a memory B cell. This memory B cell stays there for basically all your life. What happens is that when the mother gets pregnant again, so her second pregnancy, so this is your sensitization. This is now again when you're pregnant again. This baby is now also Rh basically positive. This Rh basically is released into your mother. Because now we have the memory cells, they are able to recognize this. They start to produce anti-IgG and IgM antibodies against the Royce antigen, which are able to then penetrate and go inside, specifically IgG, into your basically the newborn and start to do damage. So they start binding to the red blood cells there, and they can actually destroy them, kill them off. And basically by killing them, you're causing anemia. So basically when you have very low red blood cells, heme is being released. Heme is basically what's happening with heme is going to your liver, to your kidney, causing a lot of damage. So you get basically jaundice, because what happens with jaundice is bilirubin. Bilirubin is a protein that is found in your in your liver. And when you have too much basically damage to your liver, bilirubin is excreted and bilirubin sticks. It sticks to your skin and becomes yellow, because it sticks to your skin and also to the cornea of your eye. This is why basically this is called jaundice. Well, this is why you get yellow kind of skin or basically yellow eyes. It kind of indicates that your liver is destroyed or being destroyed. And of course, during all of this, specifically the anemia, well, you have the activation of your complement system, all these things which actually causes a lot of fluid accumulation. and this causes something called hydrops fetalis. This is extremely severe, and what happens is that the fluid accumulates so much in the fetal tissue that it actually can kill the baby. So another one is autoimmune hemolytic anemia, very very similar to technically hemolytic to hemolytic transfusion, but this case is a almost kind of an basically autoimmune disease, because for some reason something in our red blood cell, and a protein in a red blood cell, especially in its membrane, is causing us to create antibodies against it. And basically, antibodies are binding to it and causing all of these things that I said: activation of your complement, activation of your macrophages to eat up and everything. And of course, you start to have this release of heme, or what happens sometimes with macrophages, actually, they bite a piece of that, literally, red blood cell. So you get a spherocyte. So basically, this is kind of a broken red blood cell, which still can cause a lot of damage. It can cause damage to your spleen. It can cause damage to your liver. It can cause damage to your kidneys. Another one is Gutt-Pasteur syndrome. Gutt-Pasteur syndrome is basically you create a antibody response towards type 4 collagen. Type 4 collagen is basically something that's found in your basement membranes of your lung and kidneys, and specifically in your glomeruli and alveoli. Alveoli are these little sacs that are found in your lungs doing the gas exchange. Glomeruli are these kind of capillaries that are doing a lot of these kind of filtration units in the kidneys. And what happens is that they start to bind to them, and they start to activate your complement system and your immune cells to basically destroy them. So with people with Gutt-Pasteur syndrome, is you start to have a lot of these issues with the lungs and your kidneys. Another type of type 2 is myasthenia gravis. We spoke about this. So basically, this is your neuromuscular junction, and where you have basically this kind of neuron that is basically, in a junction with your muscle. It basically, in normal cases, it releases acetylcholine. Acetylcholine is able to bind specifically to acetylcholine receptors, which causes basically depolarization and basically causes your muscles to contract. What happens with myasthenia gravis the patients, they actually develop an antibody response against specifically the receptor. So they bind to the receptor, they block it, they do not allow any acetylcholine to bind, but it also can actually cause them to internalize and die, or it can cause them to basically be destroyed, either through your complement activation or basically to be phagocytosed up. So this is what usually happens in this kind of cases. So you don't have any more of these receptors, you do not get any more contractions, and you can actually be paralyzed. Another one is Graves' disease. We spoke about this as well. So in Graves' disease, what happens? This is your normal pituitary. Your pituitary gland releases T-stimulating hormones, which then go to your thyroid. They bind to basically your thyroid stimulating hormone receptor, and that causes them to release thyroid hormones. And these thyroid hormones are extremely important because they really regulate us with our metabolism, our heart, and many other processes. And generally, they carry out a lot of homeostatic processes in our body. And what usually occurs is that you have these thyroid hormones, when they're in excess, they create this negative feedback loop in which stops your pituitary from releasing TSH, because you don't want too much thyroid hormones. This can be extremely lethal. In the case of Graves' disease, you have an autoimmune disease that creates antibodies against this TSH receptors. These can actually start to activate. So this activation causes this massive increase of thyroid hormones, and despite these thyroid hormones are going back and stopping TSH being released from the pituitary, it doesn't matter. The antibodies are now activating these receptors constantly, and you get a lot of different issues. So now type 3 hypersensitivities. These are very, 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 very similar to type 2. The only difference is that they bind to an antigen that is actually that is soluble. It's not on extracellular matrix, and it's not on a cell membrane. So again, this is usually what happens when an antigen and antibody do basically combine together, and they form something that we call an immune complex. An immune complex is literally the antigen bound towards its antibody. So it's a complex formed of immune. Sorry about this, guys. I'm having allergies. I'm having literally basically rhinitis. And I can have it a bit annoyingly that I actually get to sneeze a lot. So as I said, what happens is that you have these antibodies binding to these soluble antigens. These soluble antigens, this whole immune complex, what they do is they suddenly start to deposit in blood vessels, in kidneys, joints, and the skin. And then for some, basically what happens, because they deposit there, the the membrane attack complexes, the complement activation actually happens wherever they're deposited. The macrophage starts to eat them as well because they're depositing there. And that's where damage can occur. Because if this is just simply in your cell, literally just, walking around in your blood, well, nothing happens really. It's just your macrophage comes and eats it up and that's it. But the issue here is that they deposit in certain organs that are so important that our organ becomes attacked. So I'll give you examples. One of them is systemic lupus erythematosus. So this is basically what's happening. But I love these kind of diagrams. So what happens usually is that when you have excessive apoptosis of your normal cells, you start to you have a lot of self antigens being released. And one of them that is extremely important that's being released is your double-stranded DNA. DNA per se is not, of course, immunogenic towards a B cell. It is towards to your innate immune cells, depending what they are. But in a case of these double-stranded DNA, they're covered in basically histones. These proteins that are actually being there to kind of fold your DNA. And that's basically a protein that can actually be very immunogenic. So what happens is technically our B cells start to create antibodies against those histones that are basically found in your DNA. So what happens in these cases, basically when you have the first time you basically when you have a sensitization kind of effect, the second time basically you have apoptosis and you have a release of DNA. What occurs is that the DNA has been released, it's going to bind. So the antibodies are going to bind to the histones on your DNA. They're going to come in and they're going to deposit in all around these are in your vascular beds. This could be in your kidneys, this could be in your liver, this could be in your skin, you name it. And you start getting activation of your complement system, you start getting activation of your neutrophils, your macrophages, doing a lot of damage. So this is why in this guy, this is called systemic, because it's literally going everywhere, to your kidneys, to your joints, to your skin. It's all around. And one thing that actually is very, let's say, diagnostic of SLE, so systemic lupus erythematosus, is actually this butterfly rash. For some reason, I really would love to know why this is, but patients with lupus have this butterfly rash. It's this rash that is forming here in between basically your cheeks and the nose, and it looks like a rash, hence the butterfly rash. So this is very, let's say, diagnostic wise. But I'm quite sure you've definitely have always heard of lupus. If anyone here has actually watched House, if not, please watch it. I've watched it more than 20 times, and I'm currently rewatching it again. It's one of my favorite shows. So there's always a joke that they always attribute it to lupus, but basically he's like, it's never lupus. So this is where the joke comes from. Another type 3 hypersensitivity is post-streptococcal glomerulonephritis. So the name is very complicated, but the name is actually very also easy and tells you what's happening. So what happens is that you're actually having a inflammation in your glomerulus, which are basically in your kidneys. And this is happening after streptococcus, hence post-streptococcal glomerulonephritis. Weird name. So what happens technically is that these bacteria antigens that are floating around, they start to basically have an antibody response, they bind, and they start to actually be trapped in your glomeruli, in the kidneys. So your glomeruli, so these are the capillaries, these are basically the ones that are doing the filtration. So they bind there and they start to cause a lot of damage there. So basically you have a lot of damage to your kidneys. Another one is serum sickness. Serum sickness is usually when you have a big quantity of foreign antibody that enters your bloodstream. So this is also very systemic. And technically now what's happening is that your antibodies are now binding towards them after sensitization, and they deposit in blood vessels and tissues. So, you know, you start to get this fever, there's rash, there's joint pains. These are all, you get these very weird rashes all over your skin. This is basically called serum sickness. So in a sense where you literally are sick of your own serum, so your own basically blood, because it has so much proteins in your bloodstream that are basically binding everywhere, these kind of immune complexes. Now you have then type 4. Type 4 is very different to your type 1, 2, and 3. These are more T-cell mediated. So these are more, we call them basically more like kind of delayed hypersensitivity, because this takes a bit, let's say 24 to 72 hours after your antigen exposure. So it's usually with the other ones, after your sensitization, these occur extremely quick, type 2, 1, 2, and 3. Type 4 happens 24 and 72 hours later. And these basically are mediated by either your T helper cells, your CD4 T cells, or your CD8, your cytotoxic T cells. An example is contact dermatitis. This usually happens with nickel or poison ivy. So poison ivy and nickel, they actually act as haptens. And what haptens are, these are basically proteins molecules that bind to host proteins that actually for some reason make these kind of self-proteins much more identifiable. They're able to be taken up by dendritic cells much more and actually create the T-cell response against them. So I'll show you here basically in this nice kind of figure. So this is a hapten. So let's imagine this is your poison ivy, which has these which basically enters, which now is a hapten, because this hapten will basically create this will bind to your antigen. This could be a skin protein, a cell protein. It binds to it. These basically now antigen hapten kind of complex is taken up by dendritic cells. It's taken up much more easier because for some reason the antigen is able to actually recognize very well these haptens and is able to take them up. So by accident it takes up this the skin protein, and the skin protein is then taken to your T cell, and your T cells now become sensitized. Okay. Now next time you basically get you create and of course you create a memory T cell response. After your second allergen exposure, these haptens bind to basically again to your skin protein, and then again make it much more easier to be actually recognized by your memory T cells, and they start to produce a lot of different basically molecules that can be very toxic to us. So this is basically what happens with contact dermatitis. Type 1 diabetes is, as we said, it's a bit different in the sense where like we have, for some reason, our T cells are recognizing basically let's say proteins coming from beta cells, these cells that are found in a pancreas releasing insulin. And what happens is that you have cytotoxic T cells that are going there and killing them. You also are getting CD4 T cells to come in and create a huge immune response because they're releasing a lot of different types of cytokines that are really coming, bringing macrophages and your immune cells. So guys, thank you so much for listening. I hope this was actually very easy and actually enjoyable. If you have any questions, please do let me know.